Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this education episode, we are talking about some lateral knee pain. In particular, the IT band.
Bum, 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 bum.
Ooh, I like the sound effects.
I figured I would take your spot today.
AKA the IT band. Because it's the IT band. Like, like It Girl.
All right. So this is a CEU episode. If you guys are listening to it while it is within our latest 5 CEU episodes released, then it is free, and so is our bonus content.
Yes.
If you are not, then you can go ahead and purchase it through our partner, Precision AT.
Big shout out to Precision AT.
Super big thank you. They're the ones who put all the CEUs and everything for this podcast and everything together. And the show notes is also where you will find this bonus content. So Before we get ahead of ourselves, why don't we state what we are trying to get out of this episode, Randy?
Yes, so we're going to discuss the role the IT band plays in lateral stabilization of the knee. We'll examine some risk factors that might be associated to IT band pain. We're going to discuss some different treatment options that you can use to treat IT band pain. And then we'll discuss the rehab techniques and injury prevention methods to correct dysfunction associated with IT band pain.
Why do you keep doing that?
I don't know. It's fun. Every time I write IT, the only thing I think of is it.
All right, I guess we're going to start off with our anatomy.
It's becoming very consistent. We're going with the anatomy.
Let's go for it.
And I think it's very important to talk about the anatomy of the IT band because I think it's a lot more complex than what people think it is. So essentially how it's been defined just from the idea that, I've been reading about it is it's basically fascia, a ligament, and tendon all wrapped into one structure, basically.
So basically I should throw this at my kines students who are trying to differentiate between a ligament and a tendon and just confuse them with the IT band?
Yes, absolutely. So the reason it's such a complex structure is just everything attaches to it. It attaches to everything, it seems like. It has a high amount of collagen, so it doesn't like to stretch a lot. Like, it's not really going to change its shape very much. But I think one of the most important things about the IT band is actually discussing the muscles that attach to it. And of course, everyone knows the big one or the major one that really attaches to that IT band is the TFL, right? And if you divide up how the IT band is, the TFL attaches to those anterior fibers. The next muscle that kind of gets forgotten about when you talk about IT band is the glute max. The glute max actually has a large portion attaching to the IT band. Some studies saying up to 70% of the glute max inserts into the IT band.
Wow.
Right?
That's so weird that it's not really, whenever you think of IT band, you think of TFL.
Exactly. No, the glute max actually utilizes the IT band very strongly, and it really attaches to those posterior fibers and can have a lot of influence not only on the hip, but the knee as well. Because when you think about that IT band, where's it going? Where is it inserting?
On the tibia.
That's right. And in particular, it inserts, everyone knows it, right? We've all been through our anatomy class. Gertie's tubercle, right? That's the easy insertion. Oh, Gertie's tubercle. But as you read about the IT band, it leaves you to the question, what else does this structure attach to? Because it seems to attach to everything. There are some connections to the patella through the iliopatellar band. So now you're looking at, the IT band could influence how the patella moves. And then also what I don't think gets talked about very often is the IT band actually does attach to the femur as well.
It seems like IT band's very superficial and the femur's obviously not.
Right? That's what you'd think, but there's actually a lot of deeper fibers to the IT band, and a lot of them go attached to that linea aspera, which is really deep because it's and it's also posterior.
Okay.
So you're kind of like, oh, that's weird. But these connections are kind of through other structures. Like it attaches through the intermuscular septum. So that's essentially the structure that divides the biceps femoris from the vastus lateralis. So again, you can see, does it connect to these muscles as well? And then there's also some fibers that have been called Kaplan fibers. And these structures are more distal. It's closer to the knee. And they have them like there's some proximal ones. And then the distal ones are the more thicker. And it's very close to the attachment of the lateral gastroc.
So like right by the knee.
Exactly. So again, another muscle that could kind of maybe influence the structure. And the reason I bring up Kaplan fibers is not to just bore everybody, but also it actually has been implicated in ACL reconstructions and how the IT band can actually play a huge role in stabilizing the knee in place of the ACL. And they've actually talked about when the knee's like in about 30 degrees of flexion, the IT band is actually one of the primary stabilizers.
Oh, wow. Wait, stabilizers like
right behind the ACL. The IT band plays a huge role.
As in like tibial translation?
Yes.
Oh,
and,
wow.
and I think a lot of that goes to show you how important the glute max attaching to the IT band is. Because if you flex your knee to 30 degrees, if you look at that line of pull, it goes right with that glute max. So if the glute's firing, it's pulling the IT band and resisting that anterior translation and internal rotation of the knee as well.
Which actually, that kind of makes sense too, because if it's also attaching with the biceps femoris.
Yes.
Which is also a big stabilizer in
big
tibial
time.
Translation.
Absolutely.
That makes sense.
So
look, it's all coming together.
It's all coming together. So now we kind of hinted at it, but why does all this anatomy matter? Why did I need to know Kaplan fibers? Like, how is that affecting me? And like I said, it's very important to the stabilization of that anterolateral knee. It does resist tibial internal rotation. And like we were saying, anterior tibial translation is reduced because of the IT band. But then you also will see a reduction in the medial compartment loading. So your knee arthritis people, it tends to be on that medial side. IT band plays a huge role in protecting that. And then, of course, what kind of gets forgotten is the IT band does play a role in pelvic support. Mm-hmm. Kind of like think about the glute med. Exactly. Right? That's the structure these muscles are working off of as a support base. So the IT band gives them something to, hey, this is how we're going to level off that pelvis.
Yeah. I mean, I had someone who had really weak glute meds. It was a dancer. And also really tight IT bands and lateral structures. And so that just, the more and more that she went into fifth position, which is complete external rotation of your hips and one leg anterior to the other, like just stacked like toe to heel and complete external rotation, so your feet look like an arrow. Okay. We had to treat her for trochanteric bursitis just because of that IT band rubbing over all those lateral structures.
Yeah, that's true.
And the bursa sitting there.
Big time. So now that we kind of understand why, how important the IT band is, and like clearly we've already talked about what it does in movement. I mean, what doesn't it do at this point? Now we need to talk about what's putting people at risk of sustaining IT band pain. And it's pretty consistent. I mean, a lot of it is kind of more in female athletes, but it's been pretty consistent that if you find someone who has increased hip adduction and knee internal rotation during the stance phase of running, there's a good chance they're probably going to develop some IT band pain. And it makes sense because when you think of what the IT band does, right, it's helping resist all that motion. So if you're putting it on a stretch by going into adduction, it's going to compress against the lateral femoral epicondyle, and it's going to eventually structures are going to start getting pissed off.
Right. Like exactly what we were just talking about with my dancer.
Exactly. Like the bursa on the distal end where the lateral femoral epicondyle, is, you have fat pads that sit under there that can get irritated, and just there's a lot of structures there that will get pissed off if they could just keep. I mean, anybody, if you keep pushing on someone, is going to get irritated.
Yeah.
Yeah. So don't push people. That's the moral of this episode is don't push people. So when you talk about, hip adduction, the first thing you want to think of is like, hip muscle strength, right? Those abductors are weak. And as we've talked about with other musculoskeletal conditions of the lower extremity, hip muscle strength has been pretty mixed. There's not really good evidence that says like, strength's the problem. And it's like what I've said before. When you're doing strength, you're just testing that one moment and you're testing their max ability to resist, right? That's not really functional. You know, if someone was running with their max muscle contraction, that'd be very inefficient and you'd get tired and Usain Bolt wouldn't be the runner he is today. But I think it's more of a motor control thing. I think the motor system is just, it's not controlling the motion very well. There's a delay in firing. You know, muscles aren't firing at the right time. They're not producing enough force. I think those are the bigger issues, and just doing one moment of strength testing, how the research does it is averaging 3 isometric contractions. I just doesn't, it's not functional. It doesn't give you the full picture, and I think that's why those studies show that. Another risk factor is having increased trunk ipsilateral flexion, so kind of your trunk's going towards the side that hurts or the side that will eventually hurt. Mm-hmm. And it just shows, again, poor trunk control, and then that shifting, it actually creates a dynamic valgus because you're trying to change your base of support as well.
Yeah, I mean, that makes a lot of sense.
No, absolutely.
So let's move into treating IT band pain.
Yes, because eventually, you can't prevent it all the time.
No. When someone comes to you, you're like, I know all about IT band pain, but I didn't actually get to the point where I treat it.
So one aspect, yes, the athlete will look at you very weird. They'd be like, I don't know.
Okay.
All right, but I'm still in pain. So one of the things everyone thinks about is stretching, right? I mean, we all do it. We all have our athletes stretch that IT band because, right, IT band could be tight.
I don't have my athletes stretch our IT band.
Oh, good job. Good job, because you know why? The literature is very against stretching the IT band.
Look at that. I didn't even read the literature.
Yes, like we said at the beginning, right? The IT band is very resistant to stretch. Like this thing does not like to move. Like the studies that were looking at it, before the structure actually ruptured, it only elongated like 9% of its actual length.
Is that an injury? Can someone rupture their IT band?
I think it's really hard to do.
I was going to say, that's just like a study,
essentially,
like cadaver?
It was, yeah.
Okay.
They basically took it out and like...
I hope it wasn't someone like living.
No. Good luck getting that one through IRB.
Yeah, seriously.
But yeah, so this structure does not want to move. And even if you did get to stretch, the effects of the stretch are not long lasting. So why do we see some good outcomes when you tell someone to stretch? And the reason that was proposed is because the effects of stretching are probably coming from the TFL.
Well, I was going to say, and I always tell my athletes this too, like when we're stretching something, especially the example that I use the most is the hamstring. So if I'm stretching your hamstring and let's say your calf is the one you're feeling stretching, I'm not going to stop.
Yes.
Because your calf is being stretched. And in order for you to get into this motion, that's your calf is the limiting factor.
Yes.
And so it wouldn't make sense for me to be like, no, I have to stretch the hamstring. So if you're stretching the quote unquote IT band and you're actually getting TFL length, then keep doing it.
Oh, 100%. And again, like, this is where sometimes I think people get like frustrated with research is like, oh, well, great. It's saying I can't stretch the IT band. No, if anything, it's now just a battle of semantics at this point is like, okay, yes, we're not stretching the IT band, but maybe we're stretching the TFL. And that's beneficial because the TFL acts on the IT band. Mm-hmm. And that's what this literature has shown. Like, okay, so when we stretch, where's that stretch coming from? And most of the change in length, when you include the TFL, comes from the junction between the TFL and IT band. And it shows more of a change than the rest of the IT band. I mean, to be honest, the IT band set the bar real low with only 9%. So almost anything's better than that.
Right. Well, I always tell my athletes for foam rolling, I don't have them foam roll on their IT band.
No, that's brutal.
First of all, it's painful.
That's brutal.
And you're not doing anything.
No, nothing's getting done.
Right. And so when I like change their lives when I tell them they can just foam roll on their not their IT band, their TFL.
Yeah. And the glute too. That's a good, because again, that has a big connection to the IT band as well.
And depending on the athlete, I can also talk about how the TFL, how to remember it. Tensor fasciae latae. It's your coffee muscle.
That is the coffee muscle.
You gotta roll on your coffee muscle. They're like, what?
What are you talking about?
Your latae, your tensor fasciae latae.
Duh. And then Sandra actually brought up a good point: is think about these other muscle attachments, because, like she said about the hamstring and I'm stretching my hamstring, but I feel it in my calf. I don't know if you've noticed, but the IT band connects to pretty much everything. So when you're evaluating someone with IT band pain or even treating someone, look at hamstring mobility. Does the biceps femoris have any restriction? Do they have a history of hamstring strain injury, right? That could play a role in how the IT band functions because of that connection through fascia. And same thing with the calf, the quad. So, it almost seems like, oh yeah, just throw everything at it. But everything is connected and something is going to benefit them. And that's why you use that evaluation to pinpoint those dysfunctions. When you evaluate someone with IT band pain, you don't just look at the IT band and be like, oh, well, I think it's the IT band, right? You look at other things to rule stuff out, and it can also help guide your treatment. So definitely looking at, how does the gastroc move? How is its mobility, the hamstrings, that can all play a role in tension within that IT band, creating that compression, creating that injury.
Well, also, just when was the last time you told someone to just foam roll one structure?
Oh, no, not at all.
Usually I'm like, hey, go foam roll your glutes, quads, hamstrings.
Everything.
Hip flexor.
Yeah,
everything.
Because more than likely they're not doing it at all.
No.
So they need to. All right. What are your thoughts on, this one's for the students out there. What are your thoughts on Ober's test?
I'm being quiet because you said it was for the students.
I think the students will like this question.
Honestly, I can't remember the last time I did Ober's test.
So what I thought was very interesting, when I was reading about the IT band, is they really called into question the Ober test.
Oh, really?
Yes.
Again, literature and we're just in sync.
Yes. So everyone knows, right? Ober test, it's supposed to test IT band tightness. They actually did a cadaver study to look at, does the Ober test actually test the IT band? And they actually cut a portion, the midsection of it, cut the IT band, and it didn't influence hip adduction range of motion at all.
Okay. Adduction?
Yes, adduction. But they cut the gluteus medius and the hip capsule, and both of those showed a more dramatic increase in hip adduction when using Ober test.
You know what I use more often?
What?
Is when I'm doing the Thomas test, looking at if their leg shifts laterally.
Ooh, that's a good one. I like that.
I mean, if you're already doing another test. I feel like Ober test, half the battle is having them get into position.
Yeah, and just lifting their leg.
And you're not going to fall off the table, I promise.
Yeah. So we're not saying, again, this is kind of a battle of semantics. We're not saying, oh yeah, Ober's test, trash, get it out of here. No, just we need to define what Ober test is doing, and it might not be testing the IT band.
If they're having
tightness.
Pain, then it's probably just lateral structures.
Yeah. But it could be a nice test
or tightness, I mean.
Yeah. And it could be a test to pair with your range of motion testing. Like if you do an Ober test and you kind of get that positive finding where, adduction's, restricted. Well, we know that Ober test might be a better test to test gluteus medius or the hip capsule. You compare your testing with I tested hip internal external rotation and that was pretty bad. So it's probably a hip capsule issue. So we just need to redefine what Ober test does instead of just being Ober test, trash, never using it. Right? It's not testing IT band tightness, so what's the point? No, it has a point. It's just changing that definition.
Something I do instead is have them lie on their back and have them cross one leg over the other. I think the best way I can explain this without showing it on a podcast is like if you were testing the left leg, you would take your right lateral malleolus and put it on your left LCL.
Okay.
Does that make sense?
Yes.
So like you're crossing over
Yes.
ankle over knee, and then you just hold their knee in place and you bring that leg, the straight leg, into adduction. And then that because your other leg's out of the way, the bent leg's out of the way.
Yeah.
So I find it better than Obertest because they're not guarding.
Yes.
They're not feeling like they're going to fall off the table.
And, go ahead. I'm sorry.
And they also are not like, sometimes if you don't like lift the leg over, because don't you have to do it where you're clearing the femoral head or something like that? Yeah.
The greater trochanter and stuff.
Yeah.
So also,
that's what I meant. You can't get to the femoral head. You know what I'm talking about.
But no, that actually reminds me, like, when you do like those tests, like putting them into that adduction, right? Look at the quality of the surface anatomy. You can see like if someone might have tightness in the IT band. And I know a lot of people are going to argue, like a lot of literature argues about like, oh, you can't really have tightness in the IT band. Okay, but maybe you have tightness around the fascia, around the IT band. That's what either way, something might be tight, right? Again, semantics. Look at the quality of that. And that's what I do when I evaluate someone who might have IT band pain is I look at the quality of that surface anatomy. Like if you see like the skin get really tight around there and you see like basically a divot between your lateral quad and your, lateral hamstring, there might be some tension there. I might need to work on that, right? And that can give you information.
Right.
Also, shout out to one of my favorite tests, Noble's test.
Ooh.
Yeah. The reason we don't really talk about it is just because it's kind of obvious that that's for IT band pain, right? It literally mimics the mechanism of injury, right? You compress the IT band against the lateral femoral epicondyle and then just move their leg into extension or flexion. And if it produces pain, that's positive. My favorite test. I love Noble's test. Unfortunately, there's not a lot of literature to give you numbers about how effective it is. I'm just going to say it's effective and it's awesome, so you should all be doing it.
Randy is the literature now.
All right. So that's our big TED Talk there on stretching. But obviously, we're not just going to stretch, right? We're also going to pair some rehab into this.
Right. But I think before you go into that, our bonus content has more, not just stretching, but also working on the fascia itself. So
yes.
Like IASTM, cupping, we talk about both of those things.
Yes, and I've used both in my treatment of IT band pain, and both I've seen great results. I didn't dive into any of that literature about like the actual like manual therapy uses towards IT band pain. So that's why they weren't included in the actual episode. But the bonus content will show you some techniques that, how we like to do treatment for the IT band.
Mm-hmm. And it's a bonus 0.25 CEUs.
Yes.
So that's always nice.
That's a plus.
All right, now we can go into hip strengthening.
Yes. So literature for somebody who already has IT band pain, strengthening the hip, definitely supported. 2 thumbs up. Definitely two thumbs up on that. And the reason you can feel pretty good about using that, hip strengthening is those with IT band pain have been shown to have lower hip abduction strength. And like we want to kind of preface this that, remember, that may not be the risk factor. They may not have come in with weakness in their hips, but it's their response to pain. We've talked about it before. The motor system does not like pain, right? So it's going to try and take you out of any position that might cause pain. So if those hip abductors, the abductors, are firing too much, well, it's going to put a lot of tension on the IT band. You're going to feel pain. So, hey, we're just going to turn off. Obviously, that's a problem long term.
Yep.
So we want to address that. We definitely do want to get those hips strong again. But then I would also encourage, all right, after your strengthening phase, what else can we do, right? Work on that hip muscle endurance. And I think this is where a lot of musculoskeletal injury research, prospective studies, all that stuff is going to go, right? It's going to go towards motor control and endurance. Because what happens when you fatigue? Your motor control just out the window. Things break down, things don't function right. And they've actually shown this with, doing a long run, a fatiguing run, that you get an increase in dynamic valgus. Those muscles start to turn off. They don't like to function because, well, shoot, if you're running like a marathon, like, man, everything's going to get tired by then.
Right.
So I think hip muscle endurance is a big problem. So after you hit your strengthening, go into that endurance phase to help prevent this from happening again.
All right. Is that all you have for treating?
Yes.
Okay. So moving back into, I guess this could go moving forward, I guess. If you,
yes, it is.
For prevention, you could be preventing a new injury, preventing it from recurring, or preventing in general.
Yes. And I think either way, you need to work on your proper training progression. That's always going to be key because, one, it's going to influence fatigue, right? If I'm doing, a mile today and then all of a sudden I run 20 miles the next day, which I'm not kidding. I've seen my kids do this. So it happens, right? You're going to fatigue faster, right? That's going to make your mechanics terrible. And then obviously there's that significant jump in load. I had one kid before run he was doing 4 miles on 1 week, maybe 10. And then he jumped to 30 the next week.
Wow. Did he get a stress fracture?
Oh, 100%. And you know what my favorite part was? He looked at me and be like, I don't know how this happened. Guy, I told you. Yeah, these kids. But right, so making sure that you have a proper training progression, right? It should be gradual. Nothing should be a sudden jump in anything like that. And that goes for returning to play after this kind of injury, right? You don't want to shock those tissues with too much load too fast. And then the next is use those glute exercises. On my outline, I put strengthen glutes, but obviously that's more, hey, get them to activate better. Use motor control exercises, making sure that they have proper movement mechanics. And then again, work on that fatigue resistance. If they're healthy, those glutes are probably strong. Maybe we transition into a nice endurance phase, right? Making sure that those muscles can hold up for a long exercise duration so you don't have a breakdown in mechanics. And again, work on motor control. We can always be better movers. Quality movement, is very important. So making sure it's nice and efficient and no breakdowns is very ideal into protecting these tissues.
No breakdowns.
No breakdowns.
And now it's my favorite time of the podcast that we missed in our last CEU episode. I don't know how we did.
I don't know how we did it. We just got lost in conversation.
What is our action item? Tie it up.
IT band connects to everything.
It's a good one.
And I think that's how you have to treat it. You have to treat it look at the structures that it might attach to, identify any dysfunctions, work on those, and then, of course, hip, motor control, and endurance. That should be your focus.
That was a good action item. I think it made up for us missing last time.
I think so, too.
How many references did you use for this?
I think we're sitting around 15 to 20.
Okay, nice.
Yeah.
And those will be on our website. Anything that we talk about that we're going to talk about in a second is going to be in our show notes. If you don't know how to get to the show notes, shoot us a message, but you just scroll down in any podcast or YouTube that you're watching on. Also in the show notes, you're going to find the course evaluation and quiz, link to the quiz for this. I think it is probably, I don't remember, but it's probably going to be precisionat.com/itband or something.
Pain or something. Yeah, it's kind of like part of the title in it.
Yeah.
Put in there.
So just check the show notes for that. Again, there's some other discount codes and stuff in the show notes so you can check out. And
also, again, big shout out to Precision AT. Also, if you're like, oh, I listened to all your season 1 stuff and I want my CEUs, they do offer that as well. You can purchase our season 1 content for CEUs as well through Precision AT.
And lastly, if you are a new first-time listener, we do every other episode as education like this, or stories. And next week we are going back to our stories from real athletic trainers. If you want to submit your own for a future episode, head over to our Instagram, AT Corner Podcast. And, I guess one more thing. Man, our fine print is getting so long.
So long.
Our Facebook group. If you want to be a part of our Facebook group, go to facebook.com/group/AT Corner Podcast. And that is all I have. Randy, you got anything else?
Nope, that was perfect. Thank you for helping us showcase athletic training behind the tape. Bye.